Thank you, Hélène Ries, for your inspiring and deeply moving lecture. We admire your research and we love your activism. Your work and dedication to public health have truly touched and inspired all of us today, as we can hear. Now we turn to the second part of our program, the panel discussion, entitled The Future of Global Health. And I am honored to co-chair this important session alongside a truly distinguished colleague, a very good friend, Margaret Chan, former Director General of the World Health Organization. Her visionary leadership and decades of experience have left an indelible mark of global health. Together, we look forward to engaging in a rich and meaningful discussion on the challenges and the opportunity that lie ahead of us. So, over the past few years, the world has faced unprecedented public health challenges, from the COVID-19 pandemic into the growing threat from climate change and rising health inequities, as Hélène mentioned a couple of times earlier. Today's discussions offers an opportunity to reflect on these lessons and to explore pathways toward building stronger, more resilient and equitable health systems. Before we dive into the discussion, let me introduce our three distinguished panel. Our first panelist is, of course, Dr. Hélène Ries, Executive Director of the WITS Reproductive Health and HIV Institute in South Africa, and our esteemed laureate of the Dr. Lee Jong-wook Memorial Prize for Public Health. We will have Dr. Jerome Kim, the Director General of the International Vaccine Institute. Dr. Kim is a renowned expert in virology and vaccine development, working tirelessly to promote equitable access to vaccine worldwide. And finally, we welcome Dr. Suraya Dalil, the Director of the WHO Special Program on Primary Health Care. Dr. Dalil has dedicated her career to strengthen public health care system and advancing health equity, particularly in fragile settings. So please, you can come on stage, all of us with me, the panelists, Margaret, Hélène. In the middle. Margaret, the floor is yours.
Truly, truly a great honor to be here. And Hélène Ries, I know you through and through, right? Thanks for your contribution to the World Health Organization. And of course, Suraya, thank you. And Dr. Kim, last but not the least, you're the man, the most important person in this forum, right? My dear friend, Anton, over to you. Now, the first question I like to pose, given what Hélène has told us, what is the future of public health? That is my first question.
So, who wants to start?
I could refer to my last slides at this point. Well, I think, as I said, I think that we are definitely going to have to regroup. But I don't think that we can say, let's do the same only on a lesser scale. I think we have to restructure. And we have to say, which pieces do we restructure? And it has to start by saying, what is it we want to achieve and what is going to give us the best return on investment? Things like immunization. maternal child health are obvious. But we're going to have to, as I said, rethink how we deliver health services. Integration, but also better technologies, so that we've got smarter technologies, easier to administer, easier to store, easier to transport. I mean, everything that is going to make health services better. But I do think that at the global level, the global health ecosystem needs to be reconsidered. Because if there isn't going to be money, we shouldn't be trying to run things on a third of a budget. We should then say, how do we consolidate? How do people work smarter and together? And what is that ecosystem going to look like that plays to strengths?
Okay. Now, before I give the floor to WHO, I would like to invite Dr. Kim. What do you think? The future of public health?
So it's hard to follow one of your personal heroes, but I think since the year 2000, and actually since the 1990s, we've made such incredible progress in global health. Children are alive today who wouldn't have been alive. People are living with AIDS, are dying with AIDS, with HIV rather than of it. These are really remarkable advances. We don't want to give up the advances, but at the same time we have to face the realities of maybe a restructuring of the way we had funded this. I mean, we're living in an age where official development assistance has been a tremendous contributor to a lot of the success. And you can't just replace it, as Helen said, overnight. And actually, one of my colleagues said, well, we're entering a new age, an age where ODA is still important, but there'll be less of it. So what do we really need to do? And I think Helen captured this in saying it's going to now be regional and national, and countries, individual countries, including some of the countries receiving development assistance, will need to have a stake in the future of where we're going in global health. And is this new age necessarily worse? No, actually, because in the end, countries are responsible for the health of their individual citizens. And this is maybe the first, it's not a push. We have to consider what was done to be a lot worse than that. But it's going to be a reminder. And as we regroup, rethink, and find and fill the gaps, exactly as Helen said, think end to end. So we have to really think through a process. We can't just have a vaccine. We have to have a plan to use it. We have to know that it's going to be cost effective. We're not just developing vaccines, again, to use my area of expertise, we're not just developing the vaccines for the companies. We're developing them to be used and to have impact. And then finally, this idea of cooperation, removing redundancy. Because there is redundancy. In a time when there was a lot of development assistance, there are overlapping capabilities, and we really have to be careful about that. And then prioritization, that's a horrible word, but it's one where we're looking at what we need to preserve, what we have, and what we can do better. So thanks.
Okay. WHO, you are having a difficult task.
Absolutely.
With the migration of the agenda, everything comes to you.
Yeah.
Now we are faced with the CD, NCD, innovation, AI, and the bread and butter stuff like maternal and child health, and the list go on and on and on. So how are you going to make the ecosystem work?
Great. First, it's an honor to be here and to be among the distinguished panelists. I want to speak on behalf of WHO at the beginning, but I would like to also reflect on my own ideas. Coming from a low-income country, from a fragile and a very, very kind of humanitarian setting. So first, I was really happy when I saw in your slides, Professor Riss, about the definition of health according to the WHO's Constitution of 1946. You say that health is a complete state of physical, mental, and social well-being, and not merely the absence of disease and infirmity. And I think that definition of health is as valid and important today as it was 76 years ago. So when we look at health, and we look at health from a holistic perspective and not merely the absence of disease and infirmity, then as long as human being exists on the planet, we need health, and we need health agenda, we need institutions, we need entities, bodies that uphold health and work towards health. So that's my first reflection with regards to health. The second reflection I would like to have is on gross inequalities that exist in today's world. We are in 21st century at a time where we send to a space. We are able to go and put our foot in few planets outside our own planet. We are in a situation that billions of world population are connected with digital technology. We are in a situation where family members sitting in North America speaks to family member who is in South Sudan. But yet you see that there's a gross inequality in terms of very, very basic services, be it immunization, be it antenatal care, be it services for elderly population, and so on. Or women dying from childbirth. Basically, I'm coming from a country where every 2 hours, I'm coming from Afghanistan, and that's why I would like also to reflect on that. So don't take me only as a WHO representative, where every 2 hours a woman dies from pregnancy, merely from hemorrhage. A lot of it, 2/3 of it is from hemorrhage. And you wonder that despite all those progresses that we have made in the civilization of human being, where is that equality among nations? Where's that equality among societies, among communities, and how rich countries can help countries that are poor? So I would like to go back to the global health discussion, and that discussion is that how the future would look like. I think the future to me would be, first of all, we should all accept that the system we have so far it's the right time to change. It's the right time to revisit that, and it's right time to set the new direction and the new path for the bodies, for the entities, for the institutions to respond to the population need. There are things that we need to consider into that one, and the first and foremost is national ownership. The national ownership, the countries must take responsibility for their population. Health cannot be a give and take relationship. It's like, come, provide aid, then go, and the aid will drop, will decline, or whatever. I think that model, that design is not going to work. We are in a much complex world where we have people who have comorbidities. We have situations where people do not have access to water and sanitation. We have situations where people do not have access to food. We have situations that people do not have, live with less than $1 per day. So I think the issue is that national governments should take more response, and in a genuine way. I'm not talking in terms of really like kind of high-level speeches, and in a genuine way take more responsibilities for health and for international entities and bodies to listen to the government and to national, and for the national government to listen to their population, to listen to their citizens, and that's where active citizenship comes in.
Okay.
In fact, I would also like to put women in that equation. I would also like to put young people in that equation, because no matter what, they are the stakeholders in healthcare and in provision of health. Last point, and I would really like to say that, and that's war. Because in one of your slides, you said it's about war and it's about fighting, it's about conflict. We should also do something to stop that. I think it's important that the war should be stopped, and because there is, the scale of the injuries you see, that's human-made injuries and traumas and the opportunities that are lost for millions of people because of conflict and because of human-made war and battles, all sorts of things.
You open up a can of worms. I fully agree with everything you said, all the speakers. It's very important, right? But with such a budget cut, where is money coming from? Everybody needs money. Research needs money. All the important issues you talk about, and all the alphabet soup, Gavi, CEPI, and Global Fund. Come on. We need to talk real. Okay, to talk real, I pass it to Anton.
Jérôme, I have a question for you. During the pandemic, we have seen a lot of inequity in the distribution of vaccines, of the COVID vaccine. The rich countries had, and the population in the rich countries had more vaccine than they needed and they used, when the poor countries had very late, very few doses, and in fact, despite of the great mechanism like COVAX, which tried to do more and to do better, we did not succeed. We failed. What do you think? How can we ensure better equity between countries, maybe to try to solve pragmatically in this case of vaccine? How do you see the future of a better equity in vaccine distribution in case of a new pandemic, for instance?
Are you asking me?
To Jérôme. Or maybe to you, Margaret, of course.
Well, let's talk real, okay? Vested interest, isn't it? At the end of the day, every country is doing the right thing. But when you look at, in totality, they are doing the wrong thing. Isn't it? Countries that have surplus vaccines, and Africa has nothing. So, when I was Director General at my time, it took 10 years for any innovation to go to Africa. And I keep asking the question, why? It has never been answered, right? Why does it take so long? Now, hopefully, AI this time is going to help us. You look at DeepSeek. It has changed the world because it is much more cost-effective. The developing country think that they could not afford, but because of the arrival of DeepSeek, AI is open to all. Now, can we do the same with other medical products? Over to you.
Jérôme Kim, do you want to comment on that?
Yes, so I think, when we look back at the lessons of COVID, and it's still not too late to fix some of these problems. I mean, it starts with research funding. I mean, CEPI, which did a remarkable job, the funding that it pushed out in the first 3 weeks of knowing the sequence was responsible for the generation of at least 3 of the EUL projects. But none of that funding went to the companies that make 60% of the world's vaccines. And why? I mean, if you wanted to make 2 billion doses, wouldn't you go to the people who make 2 billion doses? And none of that money went there. And I think that CEPI is gradually beginning to adjust to the reality of where vaccines are made. I think that the second question is actually a national one, because it turns out that it's not only the United States or Europe, but other countries have laws that prevent vaccines that have been purchased from being used on the basis of a national priority. So we saw that with the AstraZeneca vaccine, unfortunately, which again delayed access. The third part is, actually, and where a lot of people were critical of COVAX, but Margaret makes the point, the rotavirus vaccine was approved in the US in 2006. It was approved by WHO and recommended in 2009. Now in 2025, 60% of the world's children still don't receive all the doses of rotavirus vaccine. So the standard of care is that it takes 20 years before a vaccine really becomes used in countries that need it. COVAX and the other, the mass production of vaccines during the pandemic, 70% of the people in this world in the first year of introduction got at least 1 dose, which isn't right because the countries that needed it got it late. But maybe it means that COVAX just needs to be tweaked, and the time to fix the problems is not in the next pandemic. The time to start thinking about how to purchase, when to purchase, and how to distribute quickly is now. Why? Because we had an Mpox outbreak in DRC. It's ongoing. But we had FDA and EMA approved and a vaccine approved by the Japanese regulatory authority, all ML4, stringent regulatory authorities. We couldn't use it in DRC. Why? Because they weren't yet ready with the EUL. And as we're thinking about these things, let's take the individual cases where things haven't worked and fix them so that the next time there's an outbreak, that vaccine can be used quickly. It doesn't have to wait 3 months for a meeting that will then authorize the use of the vaccine. And then the final thing is, and I think this was addressed by Helen also, in the end, it's about giving the vaccine. And there were instances during COVID, and actually even now, where there's a huge amount of vaccines sitting unused because the systems are not in place to be able to distribute the vaccines. Now, to some extent, that can be improved with improved mechanisms of delivery. So do we depend on a cold chain of -70? Or do we have one that works at 40 degrees centigrade? Do we have ways to give things that don't require a nurse to stick a needle into a patient? And if we do, then can we get them tested and approved more quickly so that these new technologies can be used and deployed rapidly in the case of outbreaks? So again, thinking through a comprehensive solution, I think, and it's possible, and it's not going to cost, I forget the number that was put up, Helen, $50 billion, $47 billion. These are not expensive interventions, but as we think through what we need and prioritize them, we should focus on them.
I think just coming at it from another end, what happens when you don't deliver has broader repercussions. So what's happened I've seen for both pandemic flu, when we had pandemic flu and we got vaccines very late into the African region, and then with COVID, is that the population then just shrugs its shoulders and says, well, thanks and no thanks. You've been there, we don't want it, it's too late, and we won't have it. And then you have a secondary ripple effect, is that people then lose faith in the system, in the health system, but they also lose faith in this instance in bothering with vaccines. So the knock-on is quite extensive. But I do think that we need to go back and look at, as we look at the whole ecosystem, what are the models of innovative financing that would allow us to actually get some of these products out. I mentioned Gavi, I mentioned MedAccess, but there are other innovative ideas around how do we co-finance and get things out there. I think that one of the things we haven't talked about, but as we're thinking of co-financing and we're thinking about pricing being a huge block to access, is if the US does go ahead and push down prices significantly for pharma products, and you can understand why US citizens would say, actually, it's a bit unfair what's going on here, but it could change the entire pricing structure of the world. Because if pharmaceutical companies cannot get margins in high-income countries, their incentives to lower for low-income countries is lessened, the financial incentives. So we also need to think about the financial model that we have in place now and have some scenario planning in case that financial model changes. Lastly, after COVID, there's a huge excitement from the African region, led by the African Union and the heads of countries, to say, actually, we now demand our own manufacturing. And there's a lot of innovation, including from Gavi, from others, in terms of vaccine manufacturing in the African region, but not only vaccine manufacturing, but other health products. I think that the problem is that particularly for something like vaccines, that's not a quick fix for most vaccine technologies. mRNA might well be easier, but it's not necessarily going to be a solution for all vaccines. But I think the issue about vaccine manufacturing is one we definitely need to promote so that we do have access in regions to products. At the moment, as we know, less than a very small percent, less than 1% of vaccines that are used in the African region are actually manufactured in the African region. Similarly for pharmaceuticals, very little of our pharmaceutical products. That's a medium-term fix. That isn't a quick fix. So, and we have pressures here. And I think one of the things for the pandemic treaty has tried to do is to say in the event of an outbreak or an emergency that we start to conserve and dedicate a percentage, 10, 20%, that we dedicate those percentages to low-income countries who will not otherwise get access. And I think that's going to become a very important clause if we can implement that.
To Margaret, maybe. The microphone.
Can I ask a question? During my time, there was such thing as what we call PIP, and a certain percentage is dedicated for developing countries. Now, I was told that it has moved PIP to something else. So, well, it is important that the increase in the quantum, financing for developing country is much better. Now, can you help us?
No, thank you very much. I think Helen is right, but I think we probably need to also look at this comprehensively, to look at a technology transfer, a diversified production, because there's an understanding that it's not every country that will produce every single product. So the regional approach to production of vaccines, therapeutics, or diagnostics, I think is the way to go. In relation to what Helen was saying, is that the pathogen access and benefit sharing is modeled based on the PIP framework, as you correctly say. But of course, we need to understand that PIP is very specific for seasonal influenza. And here we're not dealing with a diversity of pathogens. And we don't know what kind of outbreaks we're going to be dealing with. So much as we took a leaf from the PIP book, it has to be carefully considered on how the modalities and the terms and how the operational dimensions are going to unfold. But I think the lessons were learned from the PIP framework, and Helen is right. It's actually going to be a game changer on how we make vaccines, diagnostics, as well as therapeutics available. and those percentages which are referred to as set-asides or allocations were also lessons, based on lessons that we learned from the P framework.
Thank you, Precious, for what you have done, okay?
I have a question to the panelists now, but if there is any question in the audience, please feel free to tell. There are some microphones. We will listen to you. Just before, to the panelists, I would like to come back to what Margaret mentioned about artificial intelligence. It's a game changer, for sure. My question is, do you think we would need a kind of protective agency, something like for the drugs? We are, for the medicines, we are interested in their efficacy. They are game changers in many diseases, but we are also interested in surveillance of the safety, of their safety. Do you think for artificial intelligence we should have the same for public health, for human rights and confidentiality and all these things? Do you think we should also have a protective agency at an international level regarding the use of AI in health?
I think so. I think but I don't think we've worked that one out. I mean, when we talk about reading the global infrastructure and the ecosystem, I don't think we have included that as a considerable. We're talking about what we currently have and how we rationalize what we have. But I think that the advantages, as we've listed, I mean, I listed the advantages to the health system, the advantages to using AI to the development of new drugs, new vaccines, is absolutely potentially enormous. But there are many things we don't know how to do. For example, we don't know how to regulate those products. I mean, regulatory authorities won't know how to evaluate something that has been where the scientific origin has come through AI. How are we going to do that? So I think that, I mean, this is obviously something that's getting enormous attention. But certainly there are ethical questions. There are, as you say, protection of individual rights and privacy. But there are also questions on the other side of it about technology development and how do we ensure safety. So I would agree with you that we will need to have some structures. I mean, for sure, WHO has got and will need to expand what its thinking is. But many of I know, for example, the Gates Foundation is investing a lot in AI technology, but they have a committee that's looking at the ethics of their investments in AI technology. So there are many people are thinking about this. Do we have one cohesive global solution? No. Is it being considered at the moment in this global ecosystem that we're rapidly trying to rationalize? I would say not. But should it be done in the next year or two? For sure.
We have hands up. I can see two hands. One from a woman. Okay, can you all come to the front and line up?
You need a microphone.
So, first, Helen, congratulations. This is spectacular and you deserve it. I just wanted to comment on 3 points. The first one, and this is not all my work, but I think it's important for the audience to get some of the facts. Number one, WHO is working on artificial intelligence, focusing on equity, a legal framework, and it's used for health. And there are just World Health Assembly resolutions that were endorsed by our member states, 193 of them, that will help to frame for the future how we can benefit and have an ethical approach that with access to everyone for artificial intelligence. The second one is about the country's work, and my colleague explained a lot from the community health perspective, but I just want to say that also in the pandemic treaty contents, there are clear items of discussion by our member states again that clarify several of the points that you referred to. So I will invite everybody to read the content of the pandemic treaty because it addresses almost all the points that we are discussing today that were discussed at length. Access, how to ensure that equity is not equity and distribution of products at the very end, but it goes with equity in generation of knowledge and access to research information. There are also the challenges because if everybody sets up a manufacturing facility, then the sustainability issues will kick in, and all this has been discussed. And the third is about the importance of collaboration. The pandemic treaty, as Dr. Tedros says, demonstrated that multilateralism is alive and well, and we should not retrench to work only on local things. I agree with my friend Helen that countries should work together, but there are scientific issues that should be addressed in a global way. To improve the health of others. Most of the diseases we talk about are not local. Most of the diseases of the 1,654 viruses that can cause the next pandemic are viruses that go across the continents, and collaboration is important. This is why we are very happy Helen is coordinating one of the collaborative open research consortiums for science. And then the final thing I want to say is that some of the issues of vaccine uptake have to do with what you mentioned, but also with local priorities. Helen alluded to that. Sometimes we think that the country should introduce a vaccine, but that country has other challenges of health that makes them make other decisions. So if we are going to work to increase the capacity of countries, we also have to learn to accept that their priorities sometimes will be different to ours at regional or global level. Thank you.
Hello, my name is Robert Mature. I'm the Director of Programs at Unitaid. We're a health innovation agency. Good to see you, Dr. Channon. Congratulations, Helen. Couldn't think of a more deserving recipient of this award. I just want to draw on a couple of things that you showed in your really excellent lecture to answer your question, Dr. Chan, which is a real challenge. You're saying we need to do all these things, and yet we have less resources. But in effect, what we are doing at Unitaid and working with our partners to start to identify, in fact, the resources there, they're just coming from different places. And if we simply say that we need to do things more efficiently, then the question is, how can we do that? And we saw in COVID that we were forced by the worst pandemic we've seen in a century to do things very differently and accelerate the development of life-saving vaccines in a very short time. And this crisis that we're facing now is actually compelling us to do the same. Sadly, as you said, Jerome, it happened very brutally and abruptly, so it's happening under immense duress. But it is forcing a shift in the direction we need to take around efficiency and simplification. And one example you presented, Helen, just illustratively, is long-acting prevention for HIV. Because when US funding stopped and PEPFAR's funding was pulled out from so many countries, more than commodities, life-saving commodities, was the money for healthcare services and delivery. But if you can have a long-acting preventive technology, 2 injections a year, you're going to start to address that problem. So the point we're trying to emphasize is we need to continue with the things we have and accelerate their use. But as Helen's slide showed, we can't just ask for faster horses. We have to continue to invest in the pipeline as well. Because I've been hearing, and we've been hearing that, oh, in these circumstances, innovation is a luxury. Actually, it isn't. Some innovations, which are far upstream, yes, we have to keep working at those and see how we reprioritize the funding. But others will actually make the transformations that will enable us to account for the fact that there is less money from the sources we relied on in the past, but we can get better efficiencies by using those innovations. So I might be stating the obvious, but I just wanted to re-emphasize that drawing from Helen's slides. Thank you.
Can you hear me? Right. The excellent panel. Some of them I've pleasure and to have worked with. My question is to the panel, is there a future for global health without real public health and without primary health care? I emphasize the real public health and real primary health care because we can use terminology in different ways and there's a lot of jargon and things, so the proper principles. The second question is this the right time to discuss future of global health, or we might have to wait? If you look back historically, the greatest achievement in public health was the end of wars. And Dr. Dalil said that. Maybe we might have to wait for the end of wars. When you reflect the last 2 days, what has happened, it's very shameful. And many things happening today, whether it's Sudan or other places, it's very shameful. Are we ready to stop? The other question is, can we go ahead for the future of global public health and primary health care without doing a truth and reconciliation commission to look what was done right and what was not done wrong, or what could be done better? Why I'm saying that is today there's a trust has been lost in the UN, WHO, for example, or even our governments, may it be any country. There's no trust. The people have lost trust and faith. And you must ask the question, why? The answer is very simple. Nobody is delivering services to people, with the people, by the people. The foundations of primary health care. We are not delivering services. We're just dropping products. We're dropping many things on our people, but we are not delivering the urgent services they require. So we need to look at why are we not delivering the service. It's not money. And it's not commodities. Thank you.
I can say that we are not delivering social contract, true or not. Countries are not delivering the social contract that they have signed with the people that elected them in office. So, you are right. You open up another can of worms. This is even bigger and more fundamental. Okay.
Thank you. Thank you, Chair. Probably we are sitting next to each other. Might be the question is also infectious. I am Amitavo Sarkar from Tampere University, Finland, Department of International Public Health and Epidemiology. Just a question to all the dignitaries. First of all, congrats to Professor Helen Ellis for the winning. It's really an honor to talk in front of the panel. I just go back, if I can recollect it, in 1987 or 86 in WHO Bulletin, Dr. Malhar made a single authored contribution on the muddy path of PHC. And if I go by the historic Almaty document of 78, the 8 elements, is it really possible? Because the politics and regime, they are always, they have their own interest and all. Is it really possible to have so much of bureaucratization? So from the program aspect, global health, all the programs, all the interventions can be developed based on the foundations of PHC. In fact, I again recall when Dr. Chan launched the USC, probably 2008 or 9 or 10, Dr. Malhar came that PHC comes back to the full circle. So the design of program, if it can be based on the 8 elements of PHC, and what the panel thinks, what are the threats in terms of this in the future of global health. Thank you all.
Okay, can I add one more? Okay. So thank you so much for this panel. This was truly excellent. And my name is Christine Garuya. I'm an associate professor with affiliations at Stanford and Yale University. So I'm an academic. I've been doing research for NCDs for 10 years. So if I may just slightly change the conversation towards NCDs for a moment, with Dr. Chan, of course, having the first ever high-level meeting on NCDs and the 4th coming this year, could you kindly speak to real discussion, real answer on how NCDs fits into the future of global health in terms of financing? And if I may be a little instigatory, sort of this argument that it's going to come up with primary health care or UHC, but we haven't achieved those, and there's sort of a long road to probably achieving those in a real way. So comment on NCDs and how it fits into some of your discussion on the future of global health. Thank you.
Yes, thank you. I want to have few reflections. First, about your question, Dr. Chan, on financial resources, that from where funding should come. Director General Dr. Tedros, in his opening remarks this week on Monday in the World Health Assembly, said that, which comes to the funding, he said $2.1 billion, which WHO needs for his next program budget for next 2 years, is equivalent of global military expenditure every 8 hours. He also said that $2.1 billion is the price of one stealth bomber. One bomber. That $2.1 billion is 1/4 of what the tobacco industry spends on advertising and promotion every single year. So I think when we talk about financial resources and the need for financial resources, and we put that in proportion to the rest of the world and to the other realities that's happening in our world, we need to make a sense of that how much financial resources we are talking about and for what in comparison to other spending that are being made. And I also like our dear colleague who really made my reflection easy on primary health care. In terms of how the future would look like, is we need to go back to fundamentals. We need to go back to foundations, and one of that is primary health care. It's health systems that are oriented, that are designed based on primary health care approach. And by primary health care approach, I mean the services that are closer to the population, that population go and receive them, population trust them, and there's a relationship between provider and the recipient and the population. But I also mean communities' engagement, communities' empowerment, people to have a say in what they receive, accountabilities, that they ask for better services, they ask for more financial allocation to the health services, but they also ask for accountabilities. So when we say primary health care, we are not only talking about services, which is critical, and I'm coming to that, but we're also talking about people's role, citizens' role in that one, that kind of relationship, the trust and the social contract, which is supposed to be between the people and the government. So I want to say that another audience, asked about NCDs. I think when I say we go back to fundamentals, I mean that we go back to a situation that we have a primary care, no matter which countries that might be. It might be my country, Afghanistan, it might be Sudan, it might be Australia, it might be Fiji, etc. But then you imagine that a woman comes with a child to receive vaccines. And that's, of course, important, that's excellent, but the mother comes for vaccines, but we also need to make sure that the child is screened for nutrition. The child has been screened for other diseases if there's other complaints. And the mother also receives services that she needs. Probably she needs contraception. Probably she needs anemia treatment. But also, if grandparent brings a child for immunization, maybe the primary goal is to go and to receive vaccination against measles or pertussis or TB, but also the grandparent need at that point diabetes, hypertension, cancer. So I think we need to go back to the fundamentals. We receive new vaccines, new technologies, but the delivery for that to happen for the billions of population around the world is primary health care. Unless we do that, and unless we do that in an equitable manner and prioritize that way. So future primary health care is imperative. What we need, not only financial resources, we need courage, we need commitment, we need political commitment, we need political courage, and we need our health priorities like primary health care and universal health coverage and health system should be able to survive the political turnovers, the political mandates over governments, etc.?
Well, I think it is my prerogative as the former Director General of WHO to end on time. So we have to end at 3:30, right? We are here to celebrate Li Zhongwas, okay? He was instrumental in bringing me to public health, global public health. I want to thank him. Thank you.
Thank you all, to all of you, the panelists, our distinguished lecturer, Hélène. And before we close, we would like to give to the president of the Korea Foundation for International Healthcare the last word for the closing remarks. And thank you everyone for coming and participating.